Fantastic. So appreciate everyone being willing to participate in this breakout. We've done introductions. We have a terrific group for this important conversation. I'm going to try one more time to see. No, I don't have screen share. So this is what we do. Our goal for this time together for this breakout is to think about what our goal should be as a clinical trials enterprise in order to enhance outcomes in a more person-centered and inclusive clinical trials enterprise. So I read the complete list once. I'll do it again in full now, and then let's take each one of the potential goals one by one and have you guys weigh in, maybe refine that, maybe advance it, and we'll take it from there. So the first of the goals that the working group proposed was to improve representation and relevance in the clinical trials enterprise. The second was to improve community engagement, transparency, and user-friendliness, specifically to foster trust, counter misinformation, and meet the needs of patients. The third was to demonstrate trustworthiness to the general public with respect to clinical trials. And finally, to engage and prepare a diverse clinical research workforce. So, are these the right goals? Is there anything we need to think about changing? Is there anything we need to think about adding? And to make that a little bit more specific for a group of folks who have only just met each other, what do we think about the first goal, improving representation and relevance? As we think about goal setting between now and what we hope to achieve over the coming decade, how important is that to us? And how might we go ahead and think about short-term milestones that would help us monitor if we're on the pathway to success?
Seems like representation is so critical. So I think, that's a really important goal. This is Michelle. As a company who's working on this, how do we measure that in a way that also preserves privacy? And, there's a lot of considerations around that to be able to actually establish a benchmark and know we're improving.
Great question. Lynn, you had a comment too. Thanks, Michelle.
Yeah, I was going to say it's probably the main reason for doing the other three goals in here is so that the output of the clinical trials is applicable to the whole population and not a segment of the population.
That's a really great point, Lynn, and perhaps gets a little bit to Michelle's question around if the overarching goal, if we all say we're committed to sort of improving representation and relevance, and not just in terms of lip service, but truly committed, could those things around improving community engagement, demonstrating trustworthiness, engage and prepare a more diverse and representative workforce, could we measure some of those goals as almost process measures? Is that a way to think about it? What do others think?
This is Doris. Yes, I think certainly the component of engaging community engagement, but I'm going back to look at improve the representation and relevancy. You really want that representation to be two ways. Those that are designing and carrying out the trials, but also those that are participating in the trials. And so if you're not improving that kind of diverse representation, I think even the trial would important to gain that trustworthiness in the community when the people that are touting the clinical trials are your healthcare providers. And if they are not equitably represented, you won't have that trustworthiness.
Doris, that's a great point, and I'm conscious we've got some patient and community representatives on the line. I really sort of listened carefully as Terry sort of said, come to us, we're not a free resource, really meaningfully engage us and show us value back. I wonder how we can think about some actions that we could champion in order to meet some of the really important goals that Doris lined out for us. Do you guys have any experience that you could share or recommend? Yeah, Elena, go ahead.
Yeah, I think one of the most important ways to increase engagement from the provider side, I'll just say the investigator side, is to have mentoring. And by mentoring, I mean finding those engaged in clinical trials already, who take care of large minority patient populations. There's so few Black and Brown and Native American doctors who are the principal investigators, and whether they're academic or private sector, I'm not trying to distinguish, but I think what we need is mentoring of the junior doctors, and I'll say junior, we call junior faculty, let's say, those who are 5 years out of training. And they're the most vulnerable in terms of not knowing exactly what they want to do the rest of their career. And if they have any inkling in research, they need to get engaged in clinical trial research, and finding those that are Black and Brown, Native American, I think it's very, very important. So it's a recruitment into a mentoring part of the enterprise that doesn't exist right now. What happens is the major medical groups or health systems, they get the funding to do the clinical trials without thinking about recruiting who's going to do the trials. And I think we need to have a more strategic approach to the recruitment of the next generation of clinical investigators, using the clinical investigators now who are in areas where they see lots of minority patients. So they know the barriers, they know the challenges. They may not be Black or Brown themselves. So mentoring is one activity.
Yeah, can I add to that? I would say that this is the point that Dr. Roos made is critically important. And within our own organization, as we think about the methods that we can deploy to enroll a more diverse trial population, some of them are entirely within our control. We can, for instance, simply raise awareness amongst our clinical trial teams of the importance of increasing diversity within the trials. We can identify best practices. We can connect them with partners outside the company who can help them to do so. But the one thing that we can't do by ourselves is to develop a diverse community of investigators. And for that purpose, I think that we're going to have to contemplate sort of all of society effort, perhaps a public-private partnership that's going to bring together effort and funds to develop this space. It's not something that any individual stakeholder in the community has the means to do themselves. And of course, since the benefit is going to be felt across the sector, no one is going to want to bear the burden by themselves and see others realize the benefit. So I do think a fundamental question here is what sort of effort is going to be required, and who has to participate in the development of a more diverse and representative community of investigators? Because we all recognize that that's critically important to achieving the representation goals that we seek.
This is Lana. I agree with that point very much. One of the questions I have that maybe Barry or others could address is the issue of how clinical trial training contributes or goes against tenure decisions. How are academic centers set up in a way to advance young African American and Hispanic MDs who are interested in this world, but of course have that long-standing obligation to deliver care. And I know there's been a long-standing tension on this. Is there something, to Elliot's point, where do we need to create certificate programs that can contribute to qualifications in a way that helps a young physician be interested in this world of clinical trials?
You raised it for me, so I'll just make 2 points. First, unrelated to what you asked, from my perspective, the most important thing in ensuring that there is appropriate recruitment into a study is to have the community participate in the design of the study and setting the priorities of the study. So we've learned that a long time ago. And I think that is the number one way to ensure that the study will be reflecting the community's needs and its priorities, and that the design of the study will reduce the burdens to participation and will be most appropriate for for encouraging people to participate. More specifically to Lana's point, at our institution, we have 100% protected time. We don't allow our clinical scholars, a 3-year junior physician scientist in our master's degree training program, to do any clinical work for remuneration. They volunteer to do their clinical work when they feel it's crucial for their own career development, to maintain their clinical skills for their future research goals. But I think most academic institutions are not capable of doing what we do. But I think that really needs to be looked at very, very hard. And we also have, in an attempt to make it more possible for people who come from disadvantaged backgrounds and economically to participate in our training program and become really fantastic translational investigators. On top of the NIH loan forgiveness program, I was able to get a philanthropist willing to fund an additional loan forgiveness program, because that's a major barrier and a disproportionate barrier for trainees of color. So I think that there are practical things that one can do to enrich the pool, but obviously it's you need a multi-pronged attack to make the most advances.
I think also one observation on my side is that having the conversation at the point of care, is a really important factor. So I wonder, in addition to having greater diversity across PIs, is there a way that we could develop more of a community across physicians at the point of care to begin the conversations with the patients? Because coming back to that trust, I think if the care providing physician had these conversations with patients, that would be an important entry point. And, where are those conversations, who's having them and who's not? Because I think that trust from that lens and that established relationship is so important.
Hey, Adrian, 2 comments here related to the different threads of conversation. One, in terms of just trying to engage the community and also to help be more inclusive in our clinical trials, is that we have set up a site, for example, where it's easy access for participation. So as opposed to so-called coming into our cathedral of Duke Hospital, we have something that's set up that's in the community, so it's easier access. The second thing is that actually the staffing of that is reflective of the community. So really thinking about and being very intentional, being who is hired into that to be from a broad range of backgrounds and also different cultural perspectives. One comment just on the academic cheese in terms of promotion, that I think if say efforts like this, put out, what would be standards, what are things that, would be public comparisons, I can promise you that, academic centers would move to that. And so there is an opportunity to so-called move the cheese here so that it would help develop programs and promote faculty and investigators along these pathways. Unfortunately, I think most of us don't live in Barry's world where it's easy to set aside time that's not clinical, because that is a competing interest and competing demand for many. So,
I'm sorry.
Let's do Doris Elliott, and then I want to ask one more question, and we've only got a few minutes left. But Doris, I want to make sure we come back to you.
Yes, well, just sort of 2 things in terms of the discussion that's there. I think you have the academic centers where you can train providers to participate as investigators, but also you have those in the community. we at the National Medical Association have had this long history, and we've trained a number of providers to participate as investigators. But because they were not attached to an academic center, they were not utilized. And so how long would that trained investigator wait to get onto a study and participate? And then, of course, there is the need to retrain at a certain period of time because they've gone through the good clinical practice and all of the additional requirements for certification. And so I think we have to look at it from an academic standpoint as well as from the community. And what we heard in the presentation was about community-based participatory research. So you don't want to forget those investigators.
Fantastic. Thanks, Doris. Elliot, let me come to you, and then I'm going to do a quick redirect. Barry, I do see you. I'm just conscious of time. Elliot, go.
So I would just want to suggest that we maybe broaden the scope of our inquiry a little bit around this question of representation and relevance. It's true that the relevance of our trials is limited by the lack of diverse representation, but they're also just limited by the tiny numbers of people, particularly from this country, who participate in them. And one can question how relevant the trials are when less than 1% of people with a disease state ever participate in one. I think if we want to increase the relevance of the trials, we really have to find a way just to increase the representation of everybody, to take down the barriers to trial entry, and to recruit a larger segment of the U.S. population. And I'm dwelling in the U.S. because I think a difficulty in enrolling patients into trials U.S. has compelled many of us to enroll large numbers of patients from other countries where very few people will ever receive the medicines. And unfortunately, they've also resulted in our failing to develop adequate data to inform the usage of these products by the diverse U.S. population. So I think in addition to striving to increase minority representation in our trials, we also need to strive to increase all representation in the United States. And there's lots of things we can do to achieve that.
Elliot, I'm going to riff off that for a second. Barry, then we'll close with you before Natalie does the good job of reporting back on all of our behalves. Elliot, I really like that because I think what folks have been describing so far is the sort of the interface between the sort of the clinical research enterprise as we think of it, and also the communities and all of the sort of the public and the participants that we serve, and trying to not have quite such a hard delineation there and think much more about a collaborative approach. What you did was help me sort of pivot to one of the goals we hadn't touched on, which is demonstrate trustworthiness to the general public with respect to clinical trials. I see a lot of head nodding. I just want to make sure we at least sort of cover that. That seems really important to stop it just being 1 or 2% of the population that's participating, and actually engender trust and knowledge amongst the broader public. Does that seem fair? Fantastic. Barry, I'll give you the last word, and then Natalie, on behalf of all of us, thank you for doing the report out. Hopefully we've at least teased out some threads for you. Barry, go ahead.
So we recognize the importance of working in the community, with the community. And about 14 years ago, we developed a very close relationship with Clinical Directors Network. Jonathan Tobin is actually leads a major portion of our own CTSA. And it does research in federally qualified community health centers. Those federally qualified community health centers, all of the research done there goes through a community-based review. And in addition, there's a lot of emphasis on the training of the individuals in the health centers in the conduct of doing clinical research. So I think that each academic institution really needs to develop its own unique relationships that are respectful and really supportive of both the training and the conduct of research in the community where people can gain access to it readily.
Fantastic. Barry, great closing words. Adrian and Elena, I also noted your comments. They'll be in the record too. Both of them terrific comments. Thank you, everyone. And let's head back to the main room.